Hi, everybody. Welcome to this week's quarantine video lecture. I have a special guest talking about psychiatric emergencies. This is Mrs. Karen Goodnature. She's a mobile crisis cares worker. So she actually responds to psychiatric calls in Santa Barbara County and helps those individuals through whatever kind of crisis they're going through. So Karen, if you don't mind, can you tell us all a little bit about yourself and what you do and just kind of about your job?
Sure. So in 1999, I became an EMT working in Los Angeles. At that time, they were female attendant required for all psych transports. That was my first taste of dealing with psychiatric clients at all. The following year, I transferred up to Santa Barbara County and I went to paramedic school. And here in Santa Barbara County, at the time, the paramedics provided crisis assessment for people that were suicidal, homicidal, or gravely disabled, which we'll talk about in a few minutes, and whether or not they met criteria for involuntary hospitalization. So when I completed paramedic school and I already had some experience with psychiatric patients, I volunteered for that team. So since then, I've been working directly on a crisis mental health response team, either as a paramedic initially, or now currently working for Santa Barbara County Behavioral Wellness, also known as Alcohol, Drug, Mental Health Services. Just a little bit about what we do. Currently, we have 24/7 coverage in this county, 3 different teams. There's someone on staff at all times to respond to people who are in crisis. Sometimes those people call for themselves. They might call the access line, which is an 800 number that's 24/7 manned by a therapist or someone. And they'll try to de-escalate the situation and make referrals if that's what's appropriate, or they'll call us for follow-up, for immediate follow-up. So what that looks like is that we're on standby, on call. We get a phone call from a hospital or law enforcement or sometimes a family member who's concerned about a loved one. Maybe they're concerned about themselves. If a field response is warranted, meaning that we feel like the person isn't coping well with whatever stressor is going on at the time, we'll go face to face with them and we'll start trying to figure out how can we best serve this client? Can we safety plan with this person and get them home for outpatient services?
When you say face to face, does that mean like you drive yourself to that person to wherever their emergency is happening?
Absolutely. So we respond, the CARES team, Crisis and Recovery Emergency Services team, responds to hospitals, jails, shelters, patients' homes, street corners, pretty much anywhere. I've responded into juvenile hall. Anywhere that there's a crisis with a client, we will go 24/7 and meet with them face to face.
Very similar to like a police officer or an EMT on the ambulance or a firefighter on the fire truck or anything.
Absolutely.
These are part of the 911 system.
Yeah, we're part of the mental health first responders, basically. Yeah. So the most frequent type of call that we get is for suicidal risk assessment. Suicidal clients can suffer from various sorts of triggers that might put them into crisis. It could be a breakup. It could be something with their employment. It could be a change in their housing situation. It could be a chemical imbalance, a mood imbalance, something like that. And so we never really know exactly what we're walking into until we get there and we can do some further assessment. So when it comes to what we're assessing for, we're looking for the 3 criteria: danger to self, danger to others, and grave disability. So let's take a minute and talk about that. So danger to self means a plan, intent, and the means to follow through with suicide. So for example, if somebody were to say, oh, I just wish I was dead. Okay. Are you facilitating that? Are you doing anything to make that happen? Oh, well, no, I don't have a plan. I just wish I was dead. Okay. I'm looking now at ways to support that person without taking their rights away. because that's basically what we're doing. We're writing a 5150 involuntary hold in the state of California, and we're placing them for 72 hours in a locked psychiatric facility. It's not like the movies. It's not like where they go into a padded room and they're force medicated and they're tied down or something. It's not like that. Most of the facilities are very hotel-like. They might have a roommate. They might have their own room. They never get force medicated unless they're violent towards staff or other clients. But otherwise, nobody is making anybody do anything really other than stay with supervision and support for 72 hours. Why is that? Well, we're trying to give them the opportunity to consider their options. If somebody is truly suicidal, they've had multiple stressors that have happened all at once, their coping skills have failed them, they don't have additional support available, maybe they don't have family support either. We're trying to give them a safe space for a couple of days to really sort out and let the crisis pass, kind of turn the light onto the situation and say, okay, well, these things are happening, but we do have these things available to help you. It might be counseling, it might be medication, it might be making phone calls for the client to try to figure out if they are losing their housing or if they, really are in legal trouble with some outstanding event. So usually after 72 hours, the clients are released with follow-up plans for continuing support. Some rare cases, those 5150s can be extended. It's called a 5250, and that's a week stay. But anytime we extend a hold, it involves a judge, a client representatives, like an attorney or a client patient rights advocate. It doesn't happen lightly. So when that does happen, there's usually a significant reason. At any time, those people can go voluntarily, which means that the 5150 hold is now null and void. They've changed their admission to a psychiatric facility to voluntary. And it gives them a little more power, a little more freedom in the facility to move about. But it really is empowering for them to understand that they're not being held against their will. They're there to get the help that they really need. And so that's always a good sign when somebody chooses to stay. That's really helpful.
And with
Yeah.
that form that you're talking about, that 5150, you said that it's a California legal code. And
Yeah.
as far as I'm aware, police officers can write those and psychiatric specialists like yourself. So someone
Correct.
who is trained to respond to this emergency and deal with something that is considered out of control. And that person's behavior or their attitude or, like you said, their possible suicidal ideations, those have gotten to kind of a crescendo of sorts where someone has to do something. Otherwise, this may go poorly for that individual.
I like to think of it as it's basically they've exceeded their own coping skills. And that's true for whether it be danger to self, danger to others, or grave disability. Danger to others, real quick, it's the same thing. It has to be a plan, intent, and means. You can say, oh, I hate the president. Well, okay. Well, I wish I could kill him. Okay, scary, right? But they don't have a gun. They don't have the means. They're not going to Washington. They're just, so you actually have to have an identified target, a plan, intent, and means for that to be a valid threat. Now, I'm not saying we wouldn't reach out and do some help for them and, that sort of thing. But as far as a 5150 goes, taking someone's rights away is very serious. And we try everything we can to keep someone safe and the community safe with additional support before we, take someone's rights away. Grave disability is another category. It's a little more nuanced. Grave disability means that you cannot provide for your own basic needs. So by law, that means you're not eating, not sleeping for several days, not bathing, but not just like we think of homeless not bathing. Homeless people would bathe if they had a shower available.
Right.
We're talking about people who are completely disheveled, not eating, not drinking. They think their water's poisoned. They think the government is poisoning or putting chips in their food. They might be naked inappropriately in public. Schizophrenia is usually what we think of when we think about grave disability. And typically there are a few categories that those paranoias or fixations go with. They might be fixated on the government. The government's watching them. They're bugging their house. It might be aliens. They often think that there's some sort of aliens that are inhabiting loved ones or are spying on them. They could be hypersexual as well. Sometimes that goes along with being naked in public. They're exposing themselves and that sort of thing. Hyper-religious. Frequently we hear that they think that they are an actor for God, they're an angel, or they think that they're a demon, or that someone they know is inhabited by an angel or a demon.
And I've definitely seen that on the ambulance where you respond to transport a patient who's on a 5150 Holtz. They've seen someone like yourself, and they were deemed to be a danger to themselves or gravely disabled. And then they're obviously going to mark that on that form. That form will come with me, and then in the ambulance, they'll be doing those same things. They'll say, I am this and this angel, or the devil's after me, or this or that. And they're very delusional in that time, at least to me, in my normal reality. And that's how I have to kind of phrase it, is that to them, that's their reality right now. And they're actually feeling all of that. And you can see it in their eyes.
So here's an interesting thing about delusions and psychosis in general. So, there's so much information about mental health that I could spend days and days getting into in greater detail. And I encourage anyone with any questions or any interest in any of the subjects that we're talking about to submit questions, and I will absolutely answer them in greater detail at any time. I think education about mental health and mental health crisis in particular is so important to change the stigma that's around mental health to begin with. But when it comes to psychosis, I just want you to think about something for a minute. If you believe, like you believe your name is whatever it is, if you believe that a demon is inside your body and is demanding that you kill someone else or you kill yourself, okay, that fear, that resolve, that belief is as true to them as their own name, as your own name. They 100% believe. They don't have that rationale, that sounding board to say, well, maybe that doesn't sound right. That doesn't sound typical, right? No, they are 100% in it. You can see that too. When we have a conversation, there's give and take. We pause, we acknowledge, we nod when we're talking to somebody. So when they're in the middle of responding to internal stimuli, auditory or visual hallucinations, you'll see them with very loud, pressured speech. And you'll also see them where they pause inappropriately because they're hearing a voice in their head and they're trying not to interrupt it or to wait for a break in that statement for them to speak themselves. So they'll say, my name is, and I'm an angel, and there's a demon trying to kill me. It's not because they're stuttering. They're trying to interject their thoughts in between the thoughts that are already bombarding them inside.
Wow.
So that's an interesting kind of a thing. Another interesting fact is that auditory hallucinations are one thing. Those are psychiatric in nature. Visual hallucinations are almost always substance related. So when somebody says, oh, I'm seeing dragons and, whatever, shadows are one thing. They can see a shadow. They can see a shadow, and that can be psychiatric. But when they're having full-fledged color hallucinations,
right,
more than likely that's drug related. So.
And I think we see that across psychiatric care in general, that a majority of our psychiatric conditions can be attributed to either acute or chronic use of whatever kind of drug. And it doesn't have to be, an illicit drug. It could absolutely be a pharmaceutical grade drug as well.
Yeah, 100%. Yeah, that's true. One of the questions we get about grave disability too is, well, if there's homeless people on the street, aren't they all gravely disabled? They can't provide their own shelter, right? They can't feed themselves. And the question really comes down to choice. If they were given food, would they eat it? If they were provided shelter, would they take it? An example of that is I once had a patient right outside the ambulance bay. at one of the hospitals in Santa Barbara. And this person was standing in the driveway and refused to go inside the building. God had told her she was not to go inside the building. She was to stand there silently in relationship with God, and she could not eat, drink, or go inside. So this was very stressful for her because she 100% believed that this was her command from God to do. And it took a really long time to convince her to come inside and to actually get some help. We used whatever tools we had available. We actually got the clergy from the hospital. There was a Catholic priest who was on call at the hospital. And we had him come down and intercede for her. And he was actually who got her to come inside.
I bet he was very helpful. Yeah.
He was very helpful.
Talking her language.
Yeah. So that actually brings me to the next thing. You know, when we're talking to patients, medical or trauma patients, right? They're looking to us for stability, for command, you know, that I'm in the worst day of my life. I've crashed my car, or I don't feel well, or grandma or grandpa's heart hurts and, you know, they're having a medical issue, right? So they want you to come in guns blazing. They want you to come in with your uniform and your loud voice and say, we got this. Okay. But with mental health, they may not have called you. It could be a family member or someone else. So when we walk in uniform with 4 firefighters, EMT and a paramedic, at least 2 law enforcement, and the mental health team, they're almost always sitting and we are always standing. So imagine that group of people around you and how intimidating that would be. All those badges, all those uniforms, all those people with authority that are confronting you. And you may not even think you have a problem. You're on a mission from God. Or your depression and anxiety may have been a well-kept secret for years, and now the light is on and everyone's looking at you and they're asking you, are you okay? Are you going to kill yourself? And you've got to find the words to say that in front of people that are heroes to you. It's difficult.
Yeah.
One of the ways,
it's almost like we as EMS responders, we see these patients when they've reached that point. And
they're breaking point.
Yeah, and it could have taken quite some time. Just like you said, you know, they've held this back for years. They've battled it on and off, and they have good days and bad days, good weeks. And we all have that from time to time. We all have that depression. We all have that anxiety, and that's a natural course of you know, being alive. And we overcome those, or we don't. But this person has gotten to that point where this has now overwhelmed their system. And like you said before, they've lost their ability to cope. They don't have that coping mechanism. And now we come in with this army of people, and that's kind of what it's like, especially when you have that person who's sitting on the couch. They didn't necessarily call us, and we bring in an army of people. It's very difficult to build that relationship. And I think that I know we've talked about this before, but as an EMT, as a paramedic, as a firefighter, as a police officer, as a mental health provider, we have to build that rapport with the patient. And if you were to tell the EMT students what is a good way to build that rapport, I would assume that it's to relax and talk to this person.
Right. So the first thing that I do when I get on scene, well, I do a couple of things. So I pay attention to micro expressions. Someone who's making eye contact with me, someone who's speaking in full sentences, someone who maybe is sitting forward and a little nervous versus someone who's leaning back and really is trying to like sink into the couch, you know, like how engaged are they? Right. So we're going to talk about safety, scene safety specific to mental health patients in a minute. But when it comes to building rapport, one of the most important things you can do is once you've decided that your scene is safe, okay, exit the non-essentials. If you can have law enforcement stand outside, let them do that. If you can have maybe one fire personnel who has a radio to speak to the others, stay, maybe. Let the rest go outside. If you don't need fire, cancel fire, but or whatever your protocol says. But as long as you limit the amount of people that are physically in the room when you're trying to ascertain what's going on, because if you imagine that army of helpers standing there, and maybe you've overdosed, okay, and maybe it's a female client. It's a female client, and your partner is a male paramedic, and you're a female EMT. Who do you think she's going to be more honest with or more
Right.
comfortable speaking to? So
Right.
you need to have that agreement with your partner that maybe when it comes to the questioning part, they're going to step aside and they're going to let you sit down across from the patient and say, I know this is really scary and we're here to help you. I see that you take medication. Did you take these medication this evening? Did you take all of these medication or some of them? Have you done that before? Have you taken more than was prescribed of your medication? One of the questions that I ask when it comes to medication is, I'll say, are you taking any medication? And they'll say no. And then I follow it with, are you prescribed any medication that you're not currently taking? Oh yeah, well the doctor wants me to take this, this, and this, but I don't like taking them, so I'm not. So knowing what they're prescribed versus what they're actually taking is sometimes a matter of a nuance of asking them, are you prescribed meds that you're not taking? Right?
That's a really, really good question, especially for us as emergency responders. Like, we'll ask people, do you take medicine? They say no. Or do you have any medical problems? They say no. And then we'll ask them like, well, do you take pills every day? And they're like, oh yeah, I take all these pills, but that's just what my doctor has me on.
Well, not only that, because they don't have a problem. It's
right.
managed.
It's taken care of.
It's where I'm taking medicine for that. It's not a problem. Right. So our terminology, you know, we get fuel in our vehicles. They put gas in their cars. You know, do you have a medical issue? No, I take medication. I have no issue. Right. So it's just a matter of perspective that we have to keep. So when you go in to talk to somebody, maybe you're on scene, and you've gotten there because they've overdosed or they've cut themselves or they're tearful. I know we're in a hurry to clear calls and move along. Give them a minute. Clear the room of whoever you can. Speak softly. Make micro expressions with your face that are concerned, where you're leaning forward, you're making eye contact, you're frowning when they tell you something hard, you're nodding your head that you hear them when they're saying something difficult. You don't have to solve their problems. They just want to know that you are there, that you're going to connect them with care, that you're going to be helpful. And if you need to say, it sounds like you've had a really, really difficult day, a difficult week, a difficult month. And you know what? We're going to do what we can to get you and connect you with people that can be helpful.
Right.
And that's all you need to say. But along the lines of responding to the home, I just want to say something else. It's like playing telephone. So by the time I get there, let's go with me. By the time I get there, their story has been told to the 911 dispatcher when they called. It's been told to the fire that has responded. It's been told to officers that got on scene. It's been told to the EMT and the paramedic. It's been told to an emergency doctor and their nurse. And then I walk in and I'm 8th person in line to get this information, okay? And a lot of times I'll come in and say, hi, I'm Karen. I came here, with mental health. I want to be helpful. What's going on? And they look at me with this like, are you kidding me? I've told this story 8 times. Do you people not talk?
They're fatigued at that point, right?
Right. And
from telling their story.
Gets shorter and shorter and shorter every time they tell it, because now they're just whittling down. It certainly doesn't expand every time they tell it. So when you hear something that's important, by all means, write that down on another piece of paper.
Right.
Give it to the nurse when you walk in and say, can you hand this to the mental health person? Or here's my number. Have the mental health person call me. They shared a lot of information that might be helpful. By all means, gather information and just know that by the time I get them, I'm going to get a Reader's Digest condensed version. I'm not going to hear what you heard. I'm not going to see what you saw. Pay attention to what you see. Homes that are disheveled, homes that are dirty, where dishes and everything are piled up in the sink with rotten food in the refrigerator, and maybe urine or feces on the floor, or pets' urine and feces on the floor. Pay attention to those things, because those are all indicative of people who aren't coping well in one way or another. And it may not be their baseline or their norm. So those are all important things too. I want to talk about cutting really fast. A lot of people think that people who cut are trying to kill themselves. Sometimes they say, oh, that's a cry for help. Well, yeah, it is a cry for help. They're miserable. And cutting is more often associated with childhood trauma. So people who cut, 99.999% of them, because you can never say 100 to anything, are victims of childhood trauma. It could have been sexual abuse, it could have been verbal abuse, it could have been neglect, it could be a physical, all kinds of things. But the point is, they do it to cope, and they are in control of the pain. And I'm not going to cut too deeply, but just enough so that I get that endorphin rush that helps me feel better in my brain about what's going on, right? So it's really important. It happens a lot in teenage girls, but also in some in their 20s. They don't always cut their wrists. They often cut their thighs where it can't be seen, or they'll cut their torsos where it can't be seen. I've seen some cut under their arms because their sleeves cover them. So don't assume that just because you've gotten called out for someone who's cutting, that they were actually trying to kill themselves. Usually we only get called when they cut too deeply because they've used a new object and it's sharper than they expected. I'm just saying, it's not that it's not dangerous. It certainly is, and it should be addressed, but that's not always a suicidal action. In fact, a lot of clients who cut and then go on to attempt suicide actually do it by overdose. They don't actually try to slit their wrists when they do try to kill themselves. So I always thought that was kind of interesting, that that's not even the method they would choose when it comes down to it.
That's definitely like one of the myths, right? It's one of the myths of healthcare, is that people cutting themselves is a cry for help. And a lot of time, like you're saying, from what you see in your patients, is that in reality, that's how that individual is coping. Do you have any other myths that we should be aware of as far as psychiatric calls?
Yeah, definitely. So along the lines of cutting and so forth as well, there's a disorder that's man-made. It's called borderline personality disorder. Things like bipolar and schizophrenia and anxiety, those can all be genetic and chemical imbalances. Personality disorders, and there are many of them. They might be hostility, they might be manipulative, there's all different types of personality disorders. There's hundreds of them. But what's in common with them is that they're caused by trauma, childhood trauma. And their emotional development and coping skills are stunted at the age that the trauma happened. Therefore, when you see people who are very, very manipulative, and they're very, very whiny, and they're very aggressive and demanding, and you're like, wow, you're acting like a toddler, there's a reason for that. They regress to that level of coping that worked at that time. If you're small and you use a high voice and you're a victim, people are more likely to not harm you, right? Because you pose no threat. That follows them into their adult lives. And so that's where you start seeing people that are very manipulative and self-serving. It's because they never developed out of that at the time of their trauma. So I just want to bring that up as well. Myths, I'm going to lay it on you. People say things like, oh, why don't they just take their meds? Well, why don't they just take their meds? So many reasons. It could be not having access to refills. It could be not having the money for the medications. It could be having appointments canceled. How many times a doctor canceled your appointment? Mental health is no different. Appointments get pushed, canceled all the time.
I can only imagine it's even worse right now with all the COVID.
Yeah, it is. It has been quite busy. It has been, for sure. But the biggest reason that people don't just take their meds is this. If you are bipolar, and you have very manic highs, and you do have very low lows, and you take medication to balance that, it's going to stay in the middle. Right. You're not going to feel happy, lots of love, lots of excitement, those things that feel very normal to them because they've always felt that, right? So yeah, they're not going to feel the low lows, but they're not going to feel their level of life and entertainment and engagement that they're accustomed to for their entire lives. Okay. So when we're asking someone to be med compliant, we're asking a lot of them. We're asking them to give up the very best parts of their lives in exchange for the worst parts. Okay. So a lot of times what they tell themselves is, all right, I'm feeling good right now. Everything's going well, but I'm not having sexual satisfaction like I used to. I'm not excited to go see my friends like I used to. So I'm not motivated for my job. Maybe I'm an artist and I've lost all of my influences because I'm here instead of up here thinking about the big things, So what they do is they convince themselves they're going to go off their meds temporarily. I'm going to stop taking them so I can get through this next week. But if I start to slide, I'll just start taking them again. Well, the problem is that we're terrible at recognizing our own slide. We're terrible at knowing when we should have gone back on our medication,
right,
and when we shouldn't. So I just want to say that one of the number one frustrations with EMTs and paramedics is frequent flyers. Sometimes mental health patients fall into that category because we see them over and over again before they actually get help.
as they go through their cycle.
Yeah.
Right.
The other thing is that people practice recovery. They don't just suddenly decide to stop drinking and then become sober. They don't suddenly decide to stop taking drugs and then become clean. They don't suddenly decide to become stable and then are fine. It takes practice. They're going to, like learning to walk, they're going to fall a few times before they learn to walk. So we just have to be supportive and not give up on them, not let them feel like we've given up on them. Our clients are very aware of how people feel about them. And just like the rest of the community, they hold firefighters, EMTs, paramedic, and police in high regards. They consider us all heroes as well. And seeing the look on our faces that they've let us down with their own mental health issue is really discouraging and hurtful. And it inclines them to hide their crises rather than reach out for help, because they don't want that same fire crew to come again. They don't want to hear the EMT and the paramedic talking about to the nurse about how so-and-so did this again, So there's those sorts of things too.
And I just want to say that as a provider, I find that really, really damaging to patient care when you go into the hospital and you have your own bias on a specific situation. So having seen patients come into the hospital and seeing a report given to a nurse or a doctor, this person's doing this and blah, 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 blah. And they talk it down that emergency. And that may be the time that person really needs help, and not someone who puts up a wall because they don't think that they can help that individual.
Yeah. Micro expressions are very, very important. They see you raise your eyebrows to the nurse and be like, they recognize awkward silence.
Right.
And it's not just us, the nurses will look at us instead of them. So they feel invisible. The nurse looks to you for the report, and you guys are having an exchange of micro expressions as well as verbal. Well, that patient is looking at the nurse while the nurse is looking at you. So the other thing to remember is that this is the worst day of their lives. They don't want to hear you joke with firefighters on scene. They don't want to hear you laughing before you walk into their door, because this is the worst moment this applies to all calls, not just mental health calls.
Right, definitely.
We might be responding to a stroke for grandma, and we see a fire crew we haven't seen in a really long time, and we're like, hey man, how's it going? How's your kids? Right on. And we literally walk into the door to a devastated family. For us, this is our office. It's what we do day in, day out. But for them, it's the worst moment of their lives. And that's true with mental health, the same. They are acutely aware of people's perceptions of them. And if anything we can do to help build that potential for them to follow through with treatment and to continue to reach out, super, super important. So, I do want to talk about systems and PTSD and coping and things like that. But one of the things I wanted to talk about with statistics really quick about suicide that I think is important to remember is that the highest suicide statistics rate is for adolescent and young males, teenage males, adolescent males, and then the second highest is elderly males. So their attempts tend to be more lethal, less predictable, and more final. They take more aggressive means. They'll crash a vehicle, they'll shoot themselves, they'll do something like that. Whereas females,
they make up their minds basically, and then
they're committed.
Right.
Yeah. So they're also kind of pre-wired not to ask for help by society. Strength in the tall, dark, silent type. Those are the ones that don't ask for assistance, and maybe they haven't had great coping skills all along because they were not encouraged to talk about their feelings and whatnot. I know there's a lot of stereotyping in there, but the fact remains, the statistics say teenage adult, young adult males and elderly males have the highest risk. So that's just something to be aware of.
Definitely. I've personally noticed that on calls that I respond to, when you have a male who has attempted suicide or committed suicide, it seems to be a more dangerous form, where a lot of times when you run on a female of any age group, it seems to be, pill oriented or an overdose of some kind.
True. It just is. It's true. There's a little bit of vanity involved.
Right.
Women that, think, thanks to Hollywood and the movies, that you can take pills and just go to sleep. They don't realize that you end up suffocating in your own vomit. They don't show that part when they're talking about Romeo and Juliet. Males tend to hang themselves. They tend to shoot themselves. They'll also crash their vehicles. Although I did have recently I had a teenage female crash her vehicle. Wow. Intentionally, which I was shocked. I actually was, every once in a while I get shocked after 20 years of doing crisis mental health. So any means is possible, but just know that when you've got a male, it can be kind of serious. One of the interesting things about suicide, successful suicides as well, or people that are really committed to doing it, they often leave the town they're from. So you'll get somebody in a hotel room or that's staying with friends. They leave the area that they're from. They often will give away pets, give away belongings, special things like that. They will often go on a binge spending spree. They'll just blow through all their money. They'll get a really great hotel, or they'll go out to dinner a bunch of times or something like that. People with underlying medical conditions who might be a little bit older, maybe they've got Parkinson's, maybe they've had a stroke, those sorts of things. So when you've got when you've got those underlying chronic health situations and they've left town, they've blown their money, or they've lost their job, or they've lost their relationship, those are really scary situations.
Right.
We live in a tourist area, with Santa Barbara and Solvang and so forth. And when I get a call to a hotel, I take that very, very seriously. So it's just something to be aware of,
It brings up a really interesting question for me, because you're a female and you respond, and like you said, you're the 8th person to hear this story. And there's usually a lot of people on scene, or by the time you get there, it might just be the police officers. How do you make sure that you're safe? Is that really in building the rapport with the patient, or?
Oh, that's such a good question. Okay. Thank you for bringing me back to that. That's really, really important. I think there's a really important factor of becoming sort of a chameleon. Okay. And I don't mean that you're going to be dishonest.
It's not a disingenuous. You're not being disingenuous. You're adapting to what that person needs right now. And Absolutely. That is a skill set.
Right. So what I mean by that is, if I have someone who is a little rougher around the edges, maybe they have tattoos, maybe they are speaking in a lot of slang, I'm going to change my body style. I'm not going to be sitting, with my hands folded in my lap with proper English. I'm going to drop it. I'm going to turn a little sideways. I'm going to slouch a little bit. I'm going to present a side view instead of a front view, to be like, I'm not a threat to you. I'm relaxed. I'm comfortable around you and your tattoos and your talk of drug use and your slang and your F-bombs. I'm comfortable sitting with you. And I might start speaking a little slang myself. I might talk about things that are really fucked up, to let them know that I'm a safe place for them to say what they need to say. So change your body direction. When we come in paramedics, we're like, here we are to save the day. And when we come in as mental health pros, we need to be like, I'm not a threat to you. I'm interested in what you're saying because I'm making eye contact, but my body language has shifted away from confronting you to being with you in presence. I'm presently with you. So about scene safety, one of the things that is so important, and I'm going to tell you as an example why in a second, when you go to evaluate someone, move them. Okay. Move them from their location. If they aren't physically like C-spine compromised, okay? If you go to see them and they're in their bedroom, move them to the living room. Hey, I need to talk to you for a couple of minutes. Let's go where there's some better light. Move them out of their bedroom to the couch. Why is that? They know their house better than you do. They know where everything is hidden, right? And you don't. So you want to take them out of their element and put them in yours. That's also a level of control. So when they've followed your command to leave their bedroom to their sofa, they've already
taken that first step.
They've already submitted,
right,
to you being the one in control at the moment. So as long as you don't lose that and you can maintain that control, often I'll say, you know what? Hi, it's nice to meet you, Joe. Why don't we come out here where there's a little better light and we can sit over here? And when they get up to follow me, I'm going to say, and you know what? I'm going to ask some of these gentlemen to step out. So I've also taken control over these gentlemen. I'm going to have the firefighters step out. Now I'm in authority. You followed me, they followed me, and I can be trusted. So as long as I don't break that trust or violate that trust, we're in a good position. They're going to trust me to actually help them solve their issues. So remove them from that environment. The reason I know this to be true is because I actually ran a call in Santa Barbara on the Mesa for a female that had been cutting herself. She'd actually carved into her stomach.
Oof.
I hate meat. She'd carved it. Beautiful lady, carved it into her stomach. When I got there, she was sitting on her bed in the bedroom, sitting up against her headboard. And she looked kind of rigid. And I thought, I don't like how she's backed against the wall, right? Like that whole image to me was uncomfortable, of her being backed against the wall with us standing around her bed. So I said, you know what, sweetie, let's move. Let's go over here to the table. Let's get rid of some of these people. And she hesitated just for a second. And when she hesitated, she looked down and she looked back up at me and said, okay. And we went to the table and I said, hold on a second, sweetie. I'll be at the back in just 1 second. I went to law enforcement and I said, check her bed. There's something in her bed. She had a loaded pistol behind her headboard, like right behind her pillow where she was sitting. So mind you, the call wasn't for danger to others, right? And she probably she wasn't intending to shoot me or anybody else.
But the fact remains that it was there.
Yeah, and she absolutely could have shot herself
right.
mid-evaluation or shortly after.
Right.
So, so I'm just saying, take them out of their comfort zone and move them to a different comfort zone. Right. You might want to, if you're outside with them, maybe you're in the backyard, take them to the dining room table inside and just say, you know what, let's get out of the view of the neighbors. Let's go inside for a minute. Or if you're at the kitchen table, say, you know what, can we come sit in the living room for a minute and just actually be comfortable and breathe for a second?
And when you do that, do you say, where would you like to sit? Or no, you just let them do the thing?
No, I pick it. Because again, I'm in their environment and I don't know where the danger is, right? I might actually say, like, let's say, for example, it's somebody who doesn't want me in their home. And I say, let's go over here. And they say, well, how about this room? They could have a 400-pound pit bull behind that door. Then they just want to run. So they're hoping that I'll open that door. It'll be distracting and they can get out over the fence.
Right.
That's extreme, and I don't think like that all the time, that somebody's waiting to mislead me. But when it's a matter of life and death for them, assuredly, I want to be in control of the situation and keep them as safe as possible. So I will usually, even if it's just the sofa 3 feet over, I'll be like, you know what, my eyes are bad. Would you mind if we sit over here? Or, hey, you know what, I can't quite hear you. There's a lot of distracting noise from the door. Can we sit over there? 1, I want to move them to a better environment that's more neutral. 2, I want them to submit. I want them to come with me. I want them to come with me, not just now, but 10 minutes from now and 30 minutes from now. I want them to know that I'm in control. And it's not really about manipulation or being dishonest. I need them to know
You're changing their mindset.
I am in control.
Right.
I am going to take care of you.
Right.
So follow me, We have a lot of systems in place, lots of support. We have a lot of programs that are in place. We have 24/7 crisis lines that are available. They're free. We have some that are specific, like the safety program that's specific to people under the age of 21. We have the ACT team. It's active community treatment. That's meant for folks that have chronic, debilitating mental illness, bipolar schizophrenia, that need more day-to-day follow-up. We have a triage team, where when somebody doesn't meet criteria to be involuntarily hospitalized, we can still have a teammate call them every day for the next couple of days to make sure they got connected to services, to make sure if they needed an appointment, they got it. If they needed crisis medication, they received it. And they just sort of bridge the gap. The access line, again, that's the 24/7 crisis line that somebody can call, and I'll make sure that you have those numbers to share with the class as well.
Absolutely.
And then I think that brings us back to coping and PTSD. And I'm going to ask you if you want to do a whole different section on PTSD when it comes to how much time you have. I don't know if you want to.
It's totally up to you, but I did want to say anytime you use, you're using some colorful language for what I want the EMTs to really understand. And when you say that you're going to involuntarily hold someone, that means that you're going to use that document, that 5150 document. So anytime you hear that word, involuntary hold or psychiatric hold or 72-hour hold, that's all in reference to that 5150. And that's very important for us as EMS providers, because we can't take someone from their home unless someone tells us that we legally can. So let's say I show up and I say, Karen, I'm sorry, I'm here to take you to the hospital. And you say, I don't want to go. I'm fine. I'm good to go. And I say,
my
okay,
ex-boyfriend is mad at me.
Yeah.
My ex-boyfriend is mad at me.
And I say, okay, do you know your name, where you are, what time it is, and are you okay? And you say, yes, all of those things. Please leave my house. I can't legally take you to the hospital. That would be, me force imprisoning you and assault and battery and all that stuff. So how our legal system gets around that is, or how our legal system deals with that specific crisis, is that 5150 hold. And anytime someone else hears words like involuntary hold or psychiatric crisis or 72-hour detainment, and that's what it is in California, is that 5150. It's California Penal Code. So I just want everyone to be very clear on that's what that means. And I know that you're going to hear a lot of different variations in your career, wherever anyone goes, what that specifically is. But what it comes back to is that California 5150.
It means that someone is below their functioning baseline. They're not able to function, whether it's suicidal, homicidal, or grave disability. And it's not as a result of alcohol or other substance intoxication. So you don't
write holds on people if they're under the influence then.
Correct.
You would wait until they're no longer under the influence, and then you would reassess them, even if you initially assess them and you say, this guy's high.
Well, here's an example of that. If I'm on a street corner and somebody's seeing dragons and they took off all their clothes and they're running down the street because the dragons are trying to catch them, I'm thinking it might be meth, but I don't have lab work on the street. So I'm going to put them on a 5150 hold because they're naked in public. They're running down the street. They're a danger to themselves, right? So once we get them to the hospital and they get their lab work done, and I've put them on a 5150, the ambulances came, they've taken them to the hospital, because then you have the right to do that because I signed my name, right? Saying I was taking their rights away. We get them to the hospital, we get that lab work, they get reevaluated. And now we have to say, okay, they were positive for amphetamines. Let's give them some medication to get the amphetamines out of their system. If we're no longer seeing dragons, we're walking out the door. If we
just remove that 5150.
Yeah, we release the 5150 hold.
Right.
Yeah. So again, if I were in the hospital and they were seeing dragons and I knew they were meth positive, I would start working on other sort of support for a detox placement or something, but I wouldn't be able to write a hold on them. Yeah.
Right.
So
that's good to hear, because it's a safety thing, and it's really comes down to the morality of the community, right? You're a community responder, and you're trying to make the best decision possible, just like any EMS provider is going to do the same thing. We're evaluating the situation, and then based on that evaluation, what is going to be expected of us, and that comes down to what we're taught and the community as a whole of what is normal. So you're doing what's expected. This guy's naked. He's, doing all kinds of crazy things out in the street. We've got to do something. Like, we can't just let him run around and be like, oh, he's crazy today.
Right.
And that's, we all understand that. But once he gets to the hospital, or she gets to the hospital, and they're evaluated medically, and they're like, oh, we have a medical reason for this, it's no longer a psychiatric problem.
Yeah. So that leads me to another thing to remember. Elderly patients who have urinary tract infections, elderly females, can absolutely hallucinate, absolutely be
Elderly
delusional.
males as well. Yeah, I would say
Yep,
both.
psychotic. Yep. So just know that if you get on scene and someone's delusional or they're psychotic or they're repetitive or they seem detached in some way and they're elderly, check them for a fever, look for dehydration,
Totally.
because those are things that are indicative of that. And I've seen it multiple times. It's incredible.
Just another diagnostic tool as well. Anytime someone has altered level of consciousness, obviously, you know this, for us first responders, we're going to check a blood glucose as well, because we don't want somebody acting wonky and not check a blood glucose when we have a reversible cause for that reason.
AEIOU tips.
Right.
You got to check those. And that's true for psych as well, because it could be a diabetic issue. It could be any sort of thing. And we just don't know. So yeah, it's super important. I would like to say one more thing about mental health as well, as far as our clients. We see them on their worst day. People that have bipolar disorder are not crazy. People with schizophrenia are not crazy. We all do crazy things. I've shaved my head before, right? Am I crazy? Sometimes. So it's really important that we not refer to a human being as a 5150. They're on a 5150. But when you bring a client in and you say to the nurse, this is a 5150, maybe they haven't even been evaluated yet. They're certainly not on a hold. Maybe they called and voluntarily wanted to go to the hospital because they're feeling suicidal, and that's why you transported, because they wanted to go. Okay. To refer on your radio call where they can hear you making a base report, I have a female 5150. Okay. You just called them crazy. That's what they heard. And until they're evaluated, they're not on a 5150. So just remember things like that. I've heard security staff say to medics, oh, is this one a 5150? No, they're not on a 5150. So it's just really important that we realize that there are human beings that carry these diagnoses, that have these behaviors. And we're all a stone's throw away from our worst day.
Right.
So we don't talk about them to other responders. We don't share stories that aren't for educational purposes or something, unless we're talking to peer support because it was a particularly difficult call that we ourselves needed help with, or a continuing education person or a supervisor or something like that. We just don't looky-loo mental health clients. You're going to see some things that are really interesting. The longer you're in the field, the more you'll see. But it's really important that those not become the topic of station conversations. It's just not respectful. You wouldn't want that. Even if you were running naked through Vaughn's, you wouldn't want people laughing about that back at their station. So it's really important not to pillow talk mental health crises. And the reason for that, aside from the basic human disrespect that would lead to, is God forbid you or your partner someday needs assistance. Okay. Did you know that that paramedic and EMT have the highest suicide rate of all first responders?
Wow.
Yeah. And there are several numbers, and I'm going to give them to you, for national texting and phone call hotlines for first responders. And they're free. But why is that? One, we see a lot of things and we carry them with us. Two, because of pillow talk, because of station talk, because of the three fastest forms of communication, telegraph, telephone, and telemedic, we find out a lot of things we shouldn't about people's mental health crises, right? We don't want to be that, so we don't talk about it. We don't want that to float through the station, or we don't want nurses or doctors to know that even though we're running on heart attacks every day, our own heart hurts with something else. So it's really important that if that's happening around you, you may not be able to be like, hey guys, stop, that's not cool. Maybe you can, maybe you can't, but you can remove yourself from that. You can stand up out of the break room and excuse yourself to go into the kitchen. Don't participate in things that belittle other people, even when they're not there. Because there's enough funny things that happen in this world that you can share and laugh about, that your own partner does. in a goofy way,
Yeah.
that you have to laugh at the cost of your patients. It's just not okay. And that leads to the last part about patients that I wanted to say is that the reason that I get a lot of questions, how can you do that for 20 years? How can you take care of mental health crises for 20 years? Doesn't that make you crazy? Like, don't you get tired of that? You know, whatever. And what I say to them is this: whether you're in a car accident or you have a heart attack or diabetes or a stroke, you have some culpability. You got in the car, you ate that burger, whatever it is, there's culpability for almost all medical emergencies.
Totally.
Okay? Psychiatric emergencies are not the same. They were born that way. They didn't do anything to become delusional or psychotic or suicidal. They are not lesser than we are. They are absolutely beautiful human beings that have the potential to be artists, singers, entertainers, writers, people that have different boundaries of reality when encouraged and supported, do incredible things. That same creativity, that same intensity can throw them to the very bottom, and that's when we see them. So I would encourage people to seek out famous people who have been successful with mental health issues, schizophrenic artists, bipolar artists, stuff like that. But even in our own community, they have mental health fairs. I go every year where you can buy books of poetry or artwork and things like that people with mental illness have created. So look for those things. Look for the successes in people so that you don't get frustrated when you get those calls. You know, remember that, yeah, today you saw them on their worst day, but 364 other days, they're living their best lives. You know, they're okay. So that's my feeling. These are the people that didn't ask for it. There's no culpability in what they're doing. So.
Wow. Incredible. And I think there's a lot to take away from that. Just some of the things you talked about, and just me hearing them they're impressive, where using a term like 5150 could be absolutely derogatory, especially if this person has been through this system before. Like you said, you know, sometimes they're going to trip and fall, and this may not be the first time this has happened. And when they hear that word, when they hear 5150, and we think we're talking in code, they know exactly what it means.
100%.
Yeah.
And it means to them that you've given up.
That you've written them off.
You've written them off. They're trash.
Right.
Yeah. They're just a 5150. So that's super important.
Right. One other thing that we didn't get to talk about yet was post-traumatic stress disorder, and it has various names, but PTSD is what we're calling it in this day and age. Obviously, as you look back in time, it's been surrounded around wartime situations when people are overwhelmed and they have an overwhelming stimulus, and it puts them into a state of shock. And shell shock, battle shock, and then they have, you know, military fatigue. And then as it progressed, we realized that it didn't just surround military and, you know, hostile environments. It can be absolutely happening in other parts of people's lives. And now we have PTSD, and I think there's a lot more awareness for it these days. But do you have anything to add about that specific topic?
I do. So, I'm going to give you a little bit of information about myself again here for a second. So again, I became a paramedic basically in 1999 as an EMT, and then 2000 as a medic, and worked with all that mental health stuff. But I very quickly joined what they call the Eye of the Storm, which is providing mental health support in natural disasters and emergencies. I was the regional director for the CISM, Critical Incident Stress Management Team, for our local paramedics for the entire Northern California division, meaning that I handled critical response to calls, maybe a drowning of a child or a suicide or something like that, difficult calls, MCIs and so forth.
And these are responders that are asking for help. So this is my worst call, and I'm like, oh, this is overwhelming. I need to talk to somebody.
Yep. So I managed that program, the Critical Incident Stress Management Team. I recruited peers, implemented it in this county. We had a standard protocol for a good long time about pulling units out of service automatically after a traumatic event to give them a chance to go back to the station and debrief. Having debriefings is important. A debriefing is where, you have that call. It might be a pediatric drowning, and you don't just clear and go available. You and your partner, and oftentimes the fire crew that was with you, will go back to the station, sit around a table, talk about what worked, what didn't work, and not in a critical way, in a supportive way, because your view of what happened may be different than your partner's view. You may be fixated on one portion of that call where you couldn't get the gate open, and your partner is thinking, I can't believe that you found all the stuff so quickly in the bag and handed it to me, right? But your view of it is your own. And during a debriefing, it brings in the view of everyone of the team, and it helps you process your own role in that in a better way, and helps you support your teammates by providing them the view that you had of their behavior and actions on that call. So that one of the ways to prevent EMS related PTSD is to recognize your own triggers. What is a trigger? Something that can out of the blue bring you anxiety or thoughts of, repetitive thoughts of, dark thoughts that you can't quite push away, and everybody's got different triggers. It could, it could be a loss of a job or a breakup or something like that. But for EMS people, our triggers on the calls we run are often related to triggers from our own childhood and younger lives. I think my partner's coming in a minute. So what that means is, for instance, I had a traumatic childhood. And so when I found out that when I ran on children, they stuck with me. For other people, it might be elderly who were raised by their grandparents. You see where I'm saying? Wherever you have familiarity in your younger life, when your coping skills were developing, are going to be sore spots for you when you are exposed to them in your role. So you may not know what they are. You may not know what those sore spots are, but you will when you come to them. So when you run a call that sits, when you run a call that you play over and over on a loop, when you run a call that you just can't quite shake off, or makes it so you're not sleeping so great, you are self-isolating and you're not texting your buddies quite as much, or maybe you're getting snappy with your spouse and you're realizing that, hey, after I ran that call that was a vehicle accident with those kids in it, I'm not quite myself. Reach out. It's never too late. You can do a debriefing. There is mental health support through most agencies, and certainly if there's not, we're free and we're available 24/7. But just being able to process those things and put out those spot fires will prevent a raging forest fire down the road. And I'm not saying that you won't think about those calls or that they won't be difficult, but you'll know they're coming.
Right.
And when you know they're coming, it's not a shock or a surprise, and you're able to process it. And you can set up ways ahead of time. Hey, when I get a call that does this, or this type of call, I know it's a sore spot. So I may decide that when I have that type of call, I call my wife and just tell her I love her, or I bring frozen yogurt home for my kids, or there's all these little tiny coping skills you can have that reverse that trauma and keep it from sticking on you.
It's really interesting, because you're telling me all these things for what you're looking for, as far as like you being a CISM individual for first responders. And I remember calls, specifically one call where I froze on a call. And it was a very horrific accident. I don't want to get into details, but it was a ejection on the highway, and I thought for sure this individual was dead. And I was like, okay, I'm okay. Like, this person's dead. This is not a problem. I'm going to do everything I can to try and resuscitate this individual and take them to the hospital. And rolled this individual onto a backboard, C-spine, the whole thing, and was strapping this person. And I made a mental kind of connection. I was like, wow, this person totally looks like, you know, my in-law, totally looks like an in-law. And I have this connection, like I basically know this person. They look very similar to him. And I made that connection and I was like, it's fine. And at that point, she was not dead.
Right.
And she grabbed my arm with this bloody hand and I had a full meltdown. And I didn't show anything, but I had a full meltdown. And I was like, I'm not okay. I didn't expect this. I'm not prepared. I had my guard up before and then it suddenly got through. And then after this call, my partner, you know, Mary, had to shake me and go, Justin, we've got to do stuff. And I'm like, okay. Yeah, I'm okay. All right, let's get him up in the ambulance. Let's go. You know, I'll get the dismembered foot and put it in the ambulance and do all this. And boom, go up to the hospital and go back to the station. I'm not talking. I'm just driving. I'm an EMT. I'm driving the ambulance and jibber jabber over here. And I'm not hearing it because I'm in my head and I'm playing that loop.
Yeah.
And then I go take a shower and I'm just standing there in the shower and I'm in there for like 30 minutes and I'm not okay. And I didn't know this at the time because that was the first really traumatic incident that I had. And I had been doing this EMS thing for years and I didn't know that that's what I should be looking for. And it took me weeks to recover from this with no assistance. And if I would have just spoken, and you talked about debriefings, and I want to share with everyone that it doesn't have to be like a formal debriefing with everyone involved. You can do this thing, and they've changed the verbiage a little bit, but they call it mental first aid or psychiatric first aid, where your partner sees that and they're like, oh, Justin's not acting okay. Hey, let's talk about that. And my partner tried. She tried to talk to me. She was like, are you okay? And I was like, yeah. And I just blew her off. But I wasn't. And checking in with your partner, checking in with your coworkers and being like, hey man, you need to talk about something. Like, it's totally okay. Like, we all have bad calls. Just like I'm telling you my bad call right now, it happens. And it's going to happen to you no matter what you do in life. It doesn't even have to be EMS. You will see something that affects you, and it's okay to be affected. But you have to have those coping mechanisms. And it may not be a full debriefing, but you've got to be able to talk to people. And it's okay to talk to people. So I like to share that story specifically because EMTs, paramedics, police, fire, we're all going to see stuff that's not normal.
Yeah.
And we need to be able to do mental first aid for each other.
Yeah. So one of the things to think about is I don't ask people if they're okay. They're not. I know they're not. That's why I'm there, right? So I'm not going to ask you if you're okay. And if we're on the same call, or I know that your feelings are related to a call that you ran, I might even change the tactic and say, I am still thinking about that call that we ran. Do you mind if we talk about it? This is what was upsetting to me. And I verbalize what was upsetting to me, because that opens the door for you to say, yeah, I know.
And then I feel better because you're telling me you feel bad. And now I don't feel isolated in the sense that this was a messed up call.
Yeah. Right. So anything that puts you on the same side of the table is what's important. But I never encourage anyone to say, are you okay?
Right.
The automatic response to that is, yeah, I'm fine. I mean, you could literally be like carrying your, limb over your shoulder and be like, I'm fine. It's just a flesh wound. No.
Tis but a scratch.
No. I don't need to ask you if you're fine. I know you're not, or I wouldn't be asking. What I need to do is to tell you that we're in the same boat and that I'm here to hear what you have to say. And by opening that door and saying, I'm struggling with that call that we ran. Do you mind if we talk about it for a minute so I can kind of vent it out? It puts us both back on that same side of the table.
Right.
Yeah. That's important.
Wow. Really, really impressive stuff. Karen, those are pretty much all my questions that I wanted to talk about. Do you have anything else that you wanted to add?
We talked about, I think, a lot of things, and we were kind of skipped around a little bit back and forth, but I would just say that mental health, it's like an onion. There's so many layers to it, and there's so many opportunities for you to get involved with it as well. If you want to be a part of a peer support team, or if you want to do something with an outreach team for for mentally ill in your community and that sort of thing. There's always something to learn, and there's always somewhere where you can be helpful. And like I said, if you have any questions, please, I would love to come on and answer those. Or even if somebody has a personal question they want to ask me and they don't want it brought up in front of the class or whatever, by all means, they can.
If you're okay, if you want to give me your email, I'm happy to distribute that to the students.
Yeah, 100%. And that way, if you have a question that you think is embarrassing, or you think, you just don't want on broadcast, I got you. I will answer it. I'll answer it honestly, the best I can. And I think pretty much that was it. I just thank you for, bringing the opportunity to talk about something I'm super passionate about. And I hope that we were helpful in some way. Keep yourself safe.
I think this is really important, building that expectation of how to interact is really difficult. And I think I see a lot of new individuals into EMS where they don't know how to interact, and it'll just become quiet and silent, and no one will say anything. And maybe sometimes that's what's needed, where you don't need to have a back and forth, but a lot of time you can have a productive conversation with someone who needs it, and they need that conversation.
Yeah, 100%. Yeah, it's not a competition. We're not trying to make notches on our belts or on the door frame about the worst call. You know what? I do want to say one thing before we go. You're going to have the opportunity to looky-loo a lot of things, meaning that people are going to be like, did you hear about that call? Did you hear about what medic whatever did? Oh my gosh. Or, hey, do you want to jump that? Because so-and-so is responding. Do you want to jump that? Because you want to see that vehicle accident, or you want to see that trauma. Stop. When you've done this long enough, you will find your own. Do not seek out ways to further, stress your mind or put images that you can't get out of your head. You'll have plenty of those in your own time. But when you looky-loo trauma, when you looky-loo those events that are really difficult, you end up with guilt because you weren't invited to their emergency. And so when you're gossiping about it, or you're talking about it in an unhealthy way, bantering it back and forth, or criticizing your partner's response, or your coworker's response, whatever, or we would have been there faster, or we would have done that different. When you do that sort of thing and you invite yourself to real trauma, you don't feel good about it. You end up feeling guilty. Oh, I shouldn't have seen that loss. I shouldn't have seen that death. I wasn't dispatched to it. Why did I look for no reason? I should have believed the fire department when they said, no, he's 1144, don't lift the blanket. No, I got you. I'm not lifting the blanket. I believe you. I don't need to, you cleared him? We're good. I don't need to know. Because every single time you put a drop in that bucket, you run the opportunity of springing a leak or reaching your maximum level of coping skill.
Right.
So don't look if you're not invited. Don't participate in conversations that are just, you think will be entertaining. Yeah, we learn along the way, and we learn from hearing stories about this and that in the beginning, but you need to set a boundary for yourself of where you won't go uninvited. And that's the best way you can protect yourself from unnecessary trauma exposure. So.
Wow. Thank you. Karen Goodnature, CARES Mental Crisis, Santa Barbara County. Really appreciate your time. And I think that this conversation is excellent for new members to the EMS field to hear and understand, because a lot of people feel very uncomfortable talking about psychiatric calls. And I think it's because everyone experiences it themselves at some point or another. And it's very much it's not a faux pas. It's just something that we don't talk about. And we have to be okay with expressing, that is a situation, just like you said, and it could happen, and no one asked for that.
Absolutely. Absolutely. Well,
All
thank
right.
you.
Yeah, thank you very much. This was incredible. I really appreciate it.
Anytime.
All right. And if you send me your information, I'll share it as well, okay?
I will do that.
Thanks. Bye-bye.
Bye.